चारिक, तुमने मेरे पास सिर्फ डॉक्टर राहुल का भेजा है
You are live, sir.
इंफॉर्मेशन।
Good evening, everyone. So, welcome to the first webinar of Delhi ACOIN State Chapter. And we are thankful to Delhi Ophthalmical Society for helping us in planning this program. And also Sarita Agarwal, ma'am, who is the HOD of Department of Ophthalmology of Santosh Medical College and deemed to be university soon. So, with this, we'll move forward with the program. And today's program is very special because ACOIN, it represents community ophthalmology ophthalmologists across India. And one of the major challenges nowadays is the life span of all the our current generations going higher and higher. We are getting a lot of patients with very poor vision, and for those patients, low vision aids are the new. So to say boon with which they can carry forward their day-to-day lifestyle. So for keeping that in mind, we planned this session, and we have one speaker from Dubai, of course, an Indian, and he's going to speak about the special use of contact lenses in ophthalmology. So both are somehow related, and that will help us to treat patients with very poor vision in community practice. And with this, I would like to invite the president of our Ecoin Delhi State chapter, OP Anand sir, to say a few words. Then Dr. Bhalla, the moderator for today's program, Dr. Bhalla sir will carry forward the session. Anand sir.
Uh, Thank you, Dr. Prafulla Maharanaji. I think we are one of the most dynamic secretary we are holding various type of academic activities. I really thankful to you, sir, Dr. Bhalla Saab, and other of the speakers who have selected this a very good topic. In fact, what I have seen and I've all observing in the PG exams that low vision and contact lens and for somehow the refractive part is such a weakest part of every PG student with us. And nobody have the really required knowledge for that. So really, I'm thankful that you have selected such a very vital and good topic, informing even for us that we are having such a patient terminal illness of the eye where we are not able to do anything, can't restore the vision. And in that case, we have to have the help of a low vision aids, and particularly the population who's are in the earning stage. So I think it is a really mind opening for us, and I really convey my all best wishes to all the speakers and audience for organizing such a wonderful ACOIN first meeting of the Delhi chapter. I'm really privileged and really proud to all of you. Thank you very much. I think I request Dr. Balla to carry forward the further proceedings. Dr. Balla, please.
Yeah. So, yes, as rightly pointed out by President Delhi State Chapter of ACOIN, we are organizing this wonderful seminar, which is going to be very useful for all ophthalmologists, not only the students, the postgraduate students and trainees, but even for general ophthalmologists, because this is a topic of great importance. This topic is of practical utility because once we have reached all these blinding conditions, end stage diseases, we really don't know what to do, where to refer the patients. So, with those few words, I'll like to introduce our first speaker, Dr. Rahul Raghav. He is a optometrist of repute. He has served in Center for Sight Delhi before he moved on to United Arab Emirates, where he is practicing as head optometrist in Quran Salad Medical Institute, Dubai. And he's working there since 2017 and is has great knowledge of specialty contact lenses and is also certified to fit the Euclid Emerald orthokeratology contact lenses. So, with that introduction, I'll invite Rahul Raghav to present his talk. Yeah, Rahul, please carry on from here onwards.
Good evening, everyone, and thank you so much, Doctor, to introduce me with the panelist. And I would like to thank you, DOS, to giving me opportunity to share my thoughts on special contact lenses. And I special thanks to Dr. Prafulla and Dr. Sarita Agrawal. I'm going to share my presentation now.
Full screen.
Yeah.
Yeah, perfect.
So today I'm going to talk about the special contact lenses in the complex corneal situations. As doctor said, when you have a patient in your clinic and you should think where to refer. So where the special contact lens comes, and we have to decide which lens we have to fit in the which eye and which cornea. So I'm going to talk very quickly, and I have a 10-minute time. I will try to finish in all this lenses in 10 minutes. This is my personal disclaimer. I'm a consultant for the ACOIN Care, TEDRA, and LCS. All three of them, they are contact lens company, one from Dubai, one from Spain, and one from the France. So without wasting time, let's talk about the special contact lenses. These are the lenses which falls under special contact lens category. The first one is scleral contact lenses, RGP, which is old school, still we are doing practice. Hybrid contact lenses, soft contact lens for the keratoconus, and impression-based contact lenses. I'm going to talk about in brief in my further slides. So in which conditions and where we can prescribe the scleral contact lenses. The important thing is we should know where and which lens will be uh, suitable for the which case. So special contact lenses can be benefit for the primary corneal ectasia like keratoconus, keratoglobus, secondary corneal ectasia, post-LASIK, post-RK, and PRK. Also, we can prescribe in therapeutic indications where chemical ones, exposure keratitis, filamentary keratitis, and these are some other indications where we don't look generally, but also is very important to fit for the athletes, corneal transplant patient, trauma, and even corneal scars, we can fit special contact lenses. So now first I'm going to talk about the scleral contact lenses. Scleral contact lenses are bigger in the diameter. This is hard contact lens basically. They don't touch the cornea at all. They sit on sclera always. They create the bolt between cornea and the sclera, the cornea and the lens. So the first case I'm going to present, this is I managed by scleral contact lenses. It's a keratoglobus case. I went to Kigali in Africa, Rwanda, sorry. Yeah, it's in Africa. So there is a patient, 32-year-old keratoglobus, left eye was normal myopic. And his vision was uncorrected finger counting 1 meter. And there is no refraction which we can fix. If you see the corneal topography for him, the flat cornea was 70 diopter and the steep cornea was 90 diopter. You can see the here the topography readings. The retina was fine. The doctors send it to me for the contact lens. I tried to, I planned the contact lens and I fit a scale contact lens for his right eye. And he achieved 0.7 log mark, like almost 6.9 or 6.9 parts from finger counting 1 meter. He's happy wearing the contact lenses like almost three year. Every year he comes for follow. So scleral contact lenses can manage the cornea until the cornea, steep cornea is 90. This a patient supposed to go for the surgery or something else, but the poor thing is the facility was not available in that particular clinic, and patient was like left untreated. But by scleral contact lenses, he came back to the normal visual acuity criteria. He's wearing lenses morning to evening and doing the activity daily. Another case which I also managed by scleral contact lenses is a post RK. Then he shifted to hyperopia. Then he did LASIK, then PRK, and then re-PRK. Surgeon is not giving, and he's also not don't want to give. Then he has a now corneal haze and a regular extreme flat cornea. So these are the parameters. He's 62-year-old. Post RK, hyperopia, shift, LASIK, PRK, again PRK. And if the vision was finger counting 2 meter in the right eye, 0.1 in the left eye is a log mark. Corneal reading, if you can see here, is a extreme flat. Flat K is 25 diopter and the steep K is 29 diopter in the right eye. Posterior segment was WNL within normal limit. I fitted scale contact lenses. These are the parameter for the scale lens which I fit. And he achieved in both eyes 1.0, just 6/6. Happily wearing contact lenses, comfortable, and almost 3-4 years he used to come clinic. So we manage extreme steep cornea and extreme flat cornea by scale contact lenses. This is the third case which I also manage by scale contact lenses. She's, she's a patient has post corneal transplant, pseudophakia, then people open pupils posterior synechia. She's a young lady, has a finger counting vision in the right eye, 0.6 in the left eye. If you see the keratometry already here, but the cosmetic appearance, why I put the picture, you just look at the right eye. Has because of the posterior pupil synechia, she has opacity and she's young patient. I will take 1 minute. When I when I fitted the lens, she was like very emotional because vision improved, but the cosmetic appearance was not improved because the scale contact lens was transparent. Then I worked with my team, and what we did. So this is the lens which what I fit, and she achieved 0.7 in the right eye from finger counting 1 meter, and left eye she achieved 20/26 vision, which is one. But the cosmetic appearance is still you can see the opacities. And then what we did, what we customized the lens, prosthetic scale contact lens, which was hand painted according to the left eye color. So this is the post and pre photo for the same patient. Unfortunately, I couldn't take the picture for the when I was dispensing because I work in a Arab, and generally we don't take picture for the female. So she sent me this picture, which is not that great, but still we fix the cosmetic appearance, and we improve her vision from finger counting to 0.7. So this is the power of the scale contact lenses, which sometime we can, and I will take a few seconds again. This right eye, even our cornea transplant surgeon, she said is high risk to operate for any further surgery. So she don't want to operate for any other surgery. So the patient was like untreated, same with the opacity and finger counting. Now I'm going to talk about the RGP contact lenses. It's a gas permeable hard lens, is smaller in the diameter, smaller than the cornea. We know all about the RGP lenses. Grade 2 keratoconus patient arrive in the clinic. She's 55-year-old. She doesn't want to wear glasses at all. So her vision was 0.4 and 0.6 uncorrected, and with correction 0.7 and 0.8. Topography readings are mentioned here. It was just grade 2 keratoconus. I tried to I fitted GP multifocal contact lens in both the eyes, and she achieved vision 1.0 in both eyes and N6 in the near. So why I do not put the scale contact lens for this? Because multifocal doesn't work. Scale multifocal doesn't work for the near prescription very good. So the RGP is still better when you going to fit the multifocal for the keratoconus patient. So that was the reason I planned RGP multifocal, and she is happily wearing 1.0 with the 1.0 vision for distance and 6 vision for the reading. This is the third one, third contact lenses, which called hybrid. Combination of two contact lenses. Center part is RGP and periphery the soft. They give you two different benefits. Center part will give you the benefit of RGP contact lenses, which where you can see crystal clear, and the periphery part will give you the soft contact lens comfort, and full day you can wear without any discomfort, and lens will not move in eye here to there. This is the keratoconus case. 17-year-old male guy. He has a right eye keratoconus, left eye normal, like WM within normal limit. The right eye vision was 0.505, which is 660 approx. And I plan to fit hybrid contact lenses in the right eye, and he achieved 1.066 vision. And he wear the contact lens morning 8 a.m. to 11 p.m. Here is also why I choose the hybrid contact lens for him, because if I fix the scale contact lens, he cannot tolerate more than 10 to 12 hours, and he has to remove and refill with the saline and wear it again. But he's a student. He said, I go in the morning university, I'll come back late sometime with my workshops. And so I've tried to fit the lens which works morning to evening, and same time will give the vision for him. The hybrid contact lenses in this kind of case works very well morning to evening with the comfort and a great visual acuity. This is another case for the where I fit the soft contact lenses for the keratoconus. Soft contact lenses are designed especially for the keratoconus, where the patient has impacts and post-LASIK ectasia. These lenses can be the alternative of RGP dropout patients, because the patient, those they are wearing RGP, they are not happy with the comfort and they don't want to wear the lens because the lens is moved in the eye here to there. But if you fit for these patients soft contact lens for the keratoconus, they can easily wear morning to evening, and they will be very good. They will get a good vision and comfort. So this is 41-year-old patient has a mild keratoconus. He was wearing RGP from the, because he was from the state, and state generally when they see the keratoconus, even it's a first grade, they prescribe hard contact lenses. So he was wearing hard contact lenses long time, but in Dubai weather he was not comfortable because of the weather or because of his job. He came to me and I fit a semi-soft contact lens which designed for this keratoconus. His vision improved to 1.0 in both eyes, and he came after 2 weeks for follow-up. And I asked him about the glares and uh, the comfort and all. He reported there is no glare and he's driving perfectly fine. The visual acuity, everything is fine. And now the final one is the impression-based contact lenses. The impression-based contact lenses is still not that popular. Still there's time to go, because with the lens is not easily customized and there's few laboratory only word and they are the customizing. But it can be the future for the scale contact lens, and it can be improved the high order aberrations also. Those they are the scale contact lenses are not doing, but it can be the future for the lenses. So conclusion and advantage of special contact lenses: they improve the vision, they give comfort, they give corneal protection, they hydrate the cornea, and the customization and reduction of the light and sensitivity. I would like to bring attention to my all ophthalmologist colleagues. I have a patient in a Moorfield Eye Hospital. They use the scale contact lenses to put the plasma drops they fill the lens with the plasma drops and put it in the eye to hydrate the cornea for a long period. So these some lenses can work for as a hydration also. Thank you so much. If you have any questions, please, I'm open to take. And thank you, Dost, again for giving me opportunity.
I think that was a wonderful talk, Rahul. If there are any questions, we can post it to Rahul for answering them. So Rahul, the
Rahul,
last.
nice talk. And only
Thank you.
one clarification. Is it plasma drops or is it artificial tear or tear supplement?
Plasma drops, sir. Plasma drops.
Plasma, they specifically prepare that or what?
Yes, especially prepared that, sir. Even the some laboratory from the Spain, they provide the uh, amniotic membrane abstract. It's in the powder form, and they give it to the hospital, so you can prepare in the OPD by yourself.
And they name it plasma drops.
Yeah, it's a plasma drop, sir. Corneal
Okay.
abrasions and ulcers they use, sir.
Very nice
Okay.
talk, Rahul. I just want to ask if any experience of using this scleral contact lenses in Steven Johnson syndrome.
Yes, sir. I
So
have a
because,
patient.
yeah,
Fortunately, I couldn't put here, but I have a patient. He uses lenses, and he can, like, when he enter in the OPD, he is not able to open the eye. When we put the lens, he's opening eye. He's working normal morning to evening.
so you were filling with the normal saline or artificial
Normal
tear
saline,
or
sir.
normal saline? Okay.
Yeah. If patient is really capable to
One
put the natural
question
tear
from my
drops.
side, Rahul.
Thank you, Rahul.
Yeah,
One
Dr.
important,
Sarita. Yeah. Yeah.
sir,
Please
one
carry on.
question.
Yeah.
I want to know what is the maintainable cost of these all contact lenses which you are giving for such patients. And second thing, are they expenditure is borne by the government agencies or by the insurance company?
Maintenance cost nowadays are only for the scleral contact lenses are one solution and saline drops to fill the lens.
Yeah.
This is
Okay.
the cost. Yes, some of the insurance they cover scale contact lenses in our country in UAE. Some patient they pay by themselves, but some most of the insurance they cover. Yeah.
So cost is not much. So in that
Cost
way,
cost according to Indian currency it cost almost 80 to 90,000 rupees.
80 to 90,000. Indian population cost is not less. I think if the TPAs or some kind of government like CBHS, CCHS, and some PSUs, they are many. I think it is a treatment, it's not any more cosmetic, because the most common thought block in the government agency or in the TPA is the refractive work, including the contact lens even. They think it is all glasses. They are not being covered in. So that is the main issue that I have to discuss. Thank you very
But
much. It's a
also,
good.
but I would like to bring your attention, sir. In also in UAE, if you put normal contact lens or glasses, they won't cover. But if you say it's a treatment for the keratoconus or something else, they cover it when it
Obviously.
associated with the disease.
Perfect. Thank you so much, dear.
Thank you so
I
much, sir.
think we have to really specify that these are for
But last
particularly.
question, if you allow.
Yeah,
Uh,
Dr. Sarita,
No,
please.
definitely,
yeah,
ma'am.
yeah,
You
yeah.
are you you are
Yeah,
Yes,
Rahul,
the
you are one
yeah.
of the organizers who's we really thankful
you
to you
can
for
ask to as
arranging
many
everything.
questions
Yeah.
as you want.
First of all,
And
I want to tell everyone Rahul was my student 10 years, I think 10 years back. So, Rahul, I just wanted to ask, is there any role of sterile lenses after keratoplasty just to reduce the astigmatism in patients in which there is high astigmatism?
uh, thank you so much, ma'am, for giving me opportunity and teaching me in that my past to bring me at that levels that I can answer your question. I'm so proud and I have a mixed feeling. And yes, ma'am, most of the patient we have in a UAE post transplant, ma'am. Post transplant patient we fit the
Okay.
scale contact lens.
Okay. So, means, do you think it has a good role? And how much they cost for this?
India, according to Indian INR, ma'am, 80 to 90,000 rupees for both eyes, and patient can use 2 to 3 years without replacing the lens.
Okay. 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 Thank you.
Thank you, ma'am.
Thank you.
So what, Rahul, just carrying forward. So what would you advise in these patients who have significant astigmatism post keratoplasty, scleral contact lens or a hybrid one?
Depend on the post keratoplasty. I will advise the scleral contact lens only
Scleral
because they
contact.
don't touch the cornea at all. They create the bald, so the patient will be
Nowadays,
safe.
Yeah.
nowadays, sir, after the scleral contact lens are have come up, we rarely use hybrid contact lenses because this
Yeah.
is very easy,
Right.
comfortable, so we
Hmm.
don't go for all those permutation combination. So I
Okay.
think all this question we can take up later.
Yeah.
Next, I would invite our next speaker, Dr. Mansi Tripathi. She is currently she has done her MD and senior resident from RP Center AIMS New Delhi, and she was working with our community ophthalmology department in several projects, and she also helped us in organizing and planning this program. So Mansi, please start your talk.
Good evening, everyone. Thank you, DOS and ACOIN, for giving me this opportunity to talk on low vision aids. I'll share my screen. Is it visible?
Yeah, it is visible, Mansi.
It's visible. Thank
Yeah,
you, sir.
you can do full screen now.
Yeah, thank you, sir. Okay, so talking about low vision aids, let's first revise what are blindness and visual impairment. So WHO defines blindness and visual impairment on the basis of the presenting distance visual acuity. Presenting, not corrected. So blindness is less than 3 by 60. Severe visual impairment is less than 6 by 60 to 3 by 60. Moderate visual impairment is less than 6 by 18 to 6 by 60. And early visual impairment is less than 6 by 12 to 6 by 18. And the moderate severe visual impairments and blindness constitute the group of visually impaired. Now, what on the contrast, what is low vision? So in layman terms, low vision basically refers to an inability to perform everyday or routine visual tasks such as reading, writing, or recognizing faces as a result of visual impairment. And this is the low vision that persists even after the best possible treatment, whether medical or surgical, or the best refractive correction, whether with glasses or with contact lenses, as previously discussed in the last talk so well. And low vision is comprised of the people who have best corrected visual acuity less than 6 by 18 in the better eye, but better than or equal to 3 by 60. So there are several causes of low vision in India, and especially the most of the causes are comprised of the posterior segment disorders such as AMD, glaucoma, diabetic retinopathy, retinal detachment, dystrophies, and albinism in the adults, and ROP, congenital glaucoma, and other inherited disorders in children. Now, these patients they often come to us when in our OPD it gets very frustrating and disheartening for both the clinician and the patient to explain the visual prognosis. But we can still help these patients live their independent life and empower them accordingly. So the armamentarium of low vision services, it comprises of low vision assessment, assistive devices trial, prescription of the devices, and rehabilitation. So in my talk, I'll be just covering an overview of the workup of these patients and what all devices are available to rehabilitate them. So when it comes to assessment, unlike your normal clinic and OPD that we see, the assessment of a low vision patient consists of the visual functional assessment that we do on daily basis, along with their social assessment and the assessment of the individual needs, whether the patient is a student, whether the patient is working, or whether the patient is an elderly who needs help just to go on with their daily activities. So all these assessments are extremely essential to prescribe before prescribing low vision aids. And the center of this Venn diagram is where you will get an overall complete assessment. Now, the assessment of low vision function starts from taking patient history and evaluation. How much is the duration of vision loss and what is the cause of the vision loss? A comprehensive ocular examination, visual acuity, refraction, ocular mobility, visual field assessment, and supplemental tests will help us determine. Then this is required so as to assess whether the patient has ever seen the world with their eyes or not. In younger children who are often blind by birth, they have difficulty in comprehending tasks like you and I do. So it is very important to understand that before prescribing the assistive rehabilitation devices or the low vision aids as required. Coming on to the social assessment, you need to see the patient's age, sex, socioeconomic status, as well as family demographics and the level of motivation. It takes a village to prescribe low vision services and make the patient independent and rehabilitate them. So you need to see the family demographics, what kind of aids they can afford, what they can't, and how motivated the family is to help the patient be independent. And the assessment of individual needs would require assessment of the patient's occupation, extent of the use of vision for daily different activities, what are their basic functional requirements, and the level of motivation within the patient themselves. So motivation of the family as well as the motivation of the patients are essential to be evaluated. And if it is subnormal, then it has to be addressed. Now, low vision devices can either be optical devices, which improve magnification and help the patient use whatever vision they have well. Then we have non-optical devices, which improve functionality of the existing vision. We also have nowadays electronic devices and miscellaneous devices, which we'll talk about in the later lecture. Now, when a patient with low vision comes to us, so when to redirect the patient to a low vision clinic to get the low vision aids, and when to send them for assistive rehabilitation services. So if the patient's best corrected visual acuity is more than 1/60, then they are more likely to benefit from magnifying visual aids and other visual aids. So they need a visual assessment in the low vision clinic and trial and prescription of low vision glasses. However, if the vision is less than 1/60, then it is unlikely that they would get any help with the magnifiers. So in that, we need to send them to the assistive visual rehabilitation services, identify their needs, educate, counsel, and give the trial of the devices and training and recommend the best suited devices for them. So we have several devices available for us. Which one would you choose for your patient? So coming on to the optical devices, they incorporate the lenses that achieve magnifications. Now these include microscopes, telescopes, magnifiers, prisms, and telescopic contact lenses. So coming on to the magnifiers, we have either handheld magnifiers that can be either self-illuminated or non-illuminated. These can be dome magnifiers, pocket or bar magnifiers. And we also have stand magnifiers, spectacle and digital devices. So coming on to the handheld magnifiers, this can be either illuminated or non-illuminated. Patients with retinal dystrophies such as retinitis pigmentosa and other diseases and glaucoma, they also have reduced contrast sensitivity. So you also need to increase the illumination for them. And these are plus lenses which need to be held near the spectacle planes, and they can be used for short tasks. And the patient can hold it at any distance from the eye as it is comfortable for them. However, as we discussed previously, you need to see the patient in their entirety. So this would not be suitable for patients who don't have a good hand-eye coordination. So this has a limited visual field of view, and it requires a good hand-eye coordination. So for the elderly patients with mobility disorders, with tremors, this would not be an ideal device. Another device is the bar magnifier. So as you can see, it's a cylindrical bar which acts like a paperweight, and it increases the magnification up to 3 times. It can be on top of a paper, and it can magnify the letters that are written. So this is quite helpful for people who want to read but they have low vision. Another one is a dome magnifier. So dome magnifier, it acts the same way as a bar magnifier, but it can have better magnification. And this is suitable for people with tremors because you just keep it on top of the book that they want to read, and they can just move the magnifier according to the words that they are reading. So that is how these devices can be useful. And just like dome magnifiers, there are stand magnifiers, as you can see in this picture, and these are convex lenses which are mounted on a rigid stand, and magnification also ranges according to the patient's need, again helpful for patients who might have tremors. This is another type of stand magnifier. We also have digital magnifiers nowadays, which have a tablet-like design. So this is a Zoom-Max magnifier, which can be used to read. This is actually what is written on the near vision chart, and the magnifier is kept on top of it. We can also change the color, the contrast, and the brightness, and the magnification of the letters to suit the patient's individual needs. And other type of magnifier is a pocket magnifier, which is a foldable magnifier. Patient can carry it with them in anywhere they go. This can also be illuminated or non-illuminated. Now, these were the previous ones we talked about, were devices for near, all for near work. Now, what devices would be useful for students, for example, who need to see far off screens far off, or the television, the elderly who want to watch the television. So for them, telescopes or CTV devices are very useful. So telescopes, they magnify the apparent size of distant objects, and the objects, they appear closer to the patients than they actually are. They can be either Galilean or Kelperian principle. 2 to 10 times magnifications are available. However, they're expensive, and there is a restricted field of view with these telescopes. So the telescopes could be handheld, as you see on the left side of the screen, or they can be spectacle mounted, as you can see on the right side of the screen. We also have individual spectacle mounted telescopes, as you can see, which can be put on top of the patient's own telescopes. These are helpful for patients of, say, pathological myopia who have -20, -21 number, and on top of that you can give them telescopes that can improve their vision on top of their refractive error. And similar to telescopes, we have reverse telescopes. So reverse telescope is basically like seeing from the back of a binocular. It is prescribed for patients who have good visual acuity, but they have tubular vision, just like in patients with retinitis pigmentosa or advanced glaucoma. So it increases the field of view, but it minifies whatever the patient is seeing. So this is a type of a reverse telescope. And another device is the CTV device, which can increase the magnification 2 to 3 times, and the patient can see up to 3 meters with this device quite well. Field expanders are again used for patients who have central vision loss. So they have Fresnel prisms, so patient can see eccentric. Eccentric fixation can be done by the patient, and they can see the things that they were not seeing from the macula. Now, coming on to the non-optical devices would be helpful for patients who have vision worse than 1/60, and these will help them reduce glare, reflection, increase the linear magnification. So these can be medical devices with signal or voice, such as your smartwatches these days. They are also a sort of non-optical device. Reading machines, travel devices, talking book, clocks, calculators, and watches, and typewriters with an audiological equipment, filters or tinted glasses, and most important, mobility canes. Mobility is the most basic need for independence. So a walking cane is very important for the patient to move around independently, but just giving them the walking cane is not important. One needs to know the objectives of mobility training and orientation. So the patient must be aware of their safety. They should be independent. They should be able to do the work they want to do privately, like going to a bank or submitting some confidential documents on their own. We have to ensure that there should be a certain gracefulness. It has to be inclusive, and it should be time saving to the patient. Patient should know where they are. They should know where they are going, and they should know how to reach there. So all these things are also to be taught to the patient. Just giving the walking cane is not enough. And like we talked about, tinted glasses are also important for patients such as albinism who might have increased glare. And nowadays, several smartphone apps are available to help these patients, and these can also be taught to them. And several of them are free as well. And other devices can be lamps and torches, reading stands, which can reduce the postural strain. A writing guide, if you see a blind person writing their name, they tend to write diagonally. It will help them write in a straight line, help them in exams. And similarly, there is a signature guide and notics which has different cuts for different type of currency, and those can be taught to the patient, and they can handle their own money, so they can be financially independent as well. And rehabilitation involves combining the combined and coordinated use of social, educational, vocational measures for training of these individuals to give the highest possible level of functional ability. It should cover the training for self-care and daily living. So apart from giving them the low vision aids and giving them the rehabilitation, we have to rehabilitate them for life. So they should be assisted in providing them with a disability card, a disability certification, braille literacy, and like there is in RP Center, they do have networks to help these patients with school admissions and jobs. And they must also be, they also should be educated about the government schemes and concessions that they are eligible for. So just to conclude my talk, low vision assessment, as you can see, it's an arrow. It's an ongoing arrow. It does not stop. So even after the rehabilitation, we have to see that the patient is living the best life that is possible for them. So the journey does not end at nil visual prognosis. Low vision services begin with the assessment of the individuals, and they do not stop till the patient becomes functional and independent on their own. And it is an essential tool to empower the disabled and improve their quality of life. Thank you so much for your attention.
Thank you, Mansi, that for that comprehensive, and you covered almost all the basic things that is there as low vision aids. And I hope this will help with not only students but also other practitioners. So something can be done. That should be the message from this talk. At times we have seen few physicians say nothing can be done, nothing to be done, but there is always a hope. Any question, any suggestion
Actually,
from the panelist?
Dr. Prafulla, what I want to say over here that when I was in railway, I left 2 years back. Being an institutional organization, I found number of people of all categories. Like I have selected number of class one officers in this in the department. They have to work for all kind of job. I have procured number of digital magnifiers. They have lot of advantage. Like we can change the brightness. We can change the images, the size, and we can even remember. We can record them. So just to read later on a part of that. Smart cane I have purchased my department for the totally blind people. What I have observed and I have found, I think I will request you also that we don't have any guideline for to help this kind of employee working in different organizations. Like whenever we come to the cost, how much cost we should spend to this kind of patient, when, at what time we should, procure again, and what could be the life of that. So such type of guidelines are not available. I hope the premier institute like RP Center, they should come forward to issue some guideline. I have in railway issued number of circulars to help this kind of people, and definitely we are little relieved. Otherwise, there is no provision to procure the low vision aid devices to the employee.
I think sir, Dr. Suraj is going to cover that aspect. Suraj sir is quite
Yeah.
instrumental in looking after the LV low vision aids at RP Center. Any comment or any response to what OP Anand sir suggested?
Yeah. Yeah, definitely. So we do prepare some guidelines as of today. So the only thing is like we are not able to disseminate. So hopefully, so since Praful is there, so we should be able to disseminate. Like for example, we have a guide how to use a walking cane. So because people with visual disability, what they are doing is they are just doing some kind of jugaad. So there are
Yeah.
proper training how to use working can. Just a simple example, and say how to use this DOM telescope. There are proper training we do have in our clinic in after LBR and LBR clinic. So
Okay.
so it's for us time has come to disseminate those information, those guideline in the form of like say maybe video, audio, visual, yeah, maybe some newsletter because we have a dose time and monthly. Of course, this Delhi Journal of Ophthalmology it's more on scientific, but those guideline it's not like it's just a service part. So. Praful, so we can
No, sir.
because
Yeah.
we have some mechanism to disseminate these
Sir,
guidelines because we have
ACOIN Delhi, no,
guidelines.
ACOIN is primarily dealing with this. So what
Yeah.
we can do is after from today's webinar, probably this is what the outcome should be like ACOIN Delhi State chapter plus DOS and community ophthalmology RP Center. We can work together and we
Yeah.
can come out with some guideline. It's suggested by
Yes.
our
Bilkul.
president, sir.
Yeah.
And then we'll request some maybe some pharma company or some society, or we can print out those guidelines or even in
Yeah.
e-letter, and then we can circulate that. And I hope our young bright dynamic Dr. Mansi and Sumit. Both of them will help us in that.
Yeah. A small guideline which we will frame with the coordination, I think we can submit to the Ministry of Health for their
Yes.
understanding and review.
Yeah, yeah.
So
Thank you,
just
sir.
one
Even
thing.
this
Uh,
animation is very helpful to us. What we need to develop some kind of animation, because this funding, because we need support. So without a proper support in terms of funding, so it's very difficult. Look, animation is very effective now.
No,
Say, for
ACOIN Delhi
example,
State
how
Chapter
to
will try to
train
get
this
that, sir. Yeah.
again.
so
Hmm.
also regarding referrals,
A lot of guidelines
excellent
we have.
presentation, Dr. Mansi. Uh, Also, like if we can refer a few patients for that also, sir, in that we can mention any links for referral or something
Yeah,
in the guidelines.
that can be done, Aditi. We do have
Yeah,
a LVA
yeah,
clinic, and I
right,
think
sir.
Dr. Suraj also. I think Sir is going to cover that in his talk. So let's move on. We still have two
Right.
more talks
Yeah.
left with us. So Mansi, please invite our next speaker.
So our next speaker is Mrs. Sneha Agarwal. She's a senior optometrist at Harvey Center, AIMS, and she currently looks after the low vision services and management of irregular corneas. She is responsible for managing patients of low vision services, which includes visual rehabilitation in irregular and ectatic disorders, challenging in pediatric refractions, and low vision counseling. Mrs. Sneha Agarwal has been working for low vision in low vision department for the almost last 10 years. So it would be very enlightening to hear her talk. Mrs. Sneha, over to you.
Am I audible?
Yes, you are audible. Ma'am, you are audible.
Uh,
You
thank you.
may go to full screen and start your.
Yeah.
Yeah, thank you. Thank you for today's talk. So I'm going to talk about pearls to prescribe low vision aids. As it has already been discussed that, what is the essence of low vision devices and how the assessment begins. So the assessment begins as soon as the patient enters the room. So as the patient is entering the room, we just get a lot of information whether the patient is moving independently, whether the patient is looking for any support, is he using any cane or so, what kind of glasses the patient is wearing. So as Dr. Mansi mentioned, it is not the low vision is the functional effects of low vision. Even if the patient has PL positive 1/60, the actual definition might be different, but the how we can enhance the residual vision with the help of low vision devices, it can be either the optical, non-optical, or the digital aid. So, there can be the different challenges along with the vision loss. Like if there is a central vision loss in cases of macular degeneration of toxoplasma scar, the patient might have, presentations for difficulty in reading, problems with writing, completing paperwork, inability to recognize faces, and as per the loss in peripheral vision in RP or glaucoma, they might complain of mobility or navigation. Reading peripheral field and the visual field is very constricted, so they might have to move their heads. Or cloudy media in corneal scars or vitreous hemorrhages, there is overall blurred vision, reduced contrast, and they struggle with glare challenges. So the overall aim of low vision services is to make the patient more apt, more capable, and to reduce the time individuals do spend with their visual disabilities by providing suitable optical and non-low, like low vision devices, and to make their life better by vocational or occupational or any type of rehabilitation program. So the course begins with identifying the visual challenges and evaluating their visual functioning by the comprehensive low vision evaluation. We must emphasize the need, and we try to improve their visual acuity by the suitable glasses or non-optical spectacles or aids. We must inform and educate these patients because they have a lot of queries, and they are initially there is high hardcore unacceptance that their vision cannot be improved by simply glasses or any medical management or surgery. So they try to seek you from various means. that is there any way, is there any surgical or where we can be referred to. So you need to guide them and educate them about their condition, about their visual conditions, and what are the benefits, or so how they can get the low vision devices, and we must empower and educate them. So increase access for evaluation and rehabilitation. So we must be oriented towards activities of daily living. We must give them appropriate technology. The devices must be cost effective, and they must be utilized for educational and vocational adaptation. They focus on target group because there are low number of low vision aids, as Dr. Mansi showed in her presentation, ranging from telescope to Ocultech glasses to CTV spectacles. What suits them the best? What is comfortable as per their economical conditions and their needs? How much those devices can be used in their day-to-day life? These kind of questions must be answered, and if needed, the environment perception can be altered, or the environmental modifications can be brought into their lifestyle modifications. So, the whole concept is to make the things bigger, bolder, and brighter. And how the low vision function is by bringing the devices or objects closer. We must change their colors, and contrast must be enhanced. So, as we are doing this process of making the things bigger, bolder, and brighter, we must keep, in mind the few optical disadvantages, or, the side effects of making the things bigger, bolder, and brighter, because we might have unwanted pincushion distortions or closer unwanted closer reading distance. Making the things bolder beyond requirement make the can make the images looks very colossal, and they might be difficult to read in one go. And excessive brightness can be it can be annoying to the patient. And what level of, or what kind of illumination we are giving, with the yellow illumination or white illumination, and where the illumination is kept, whether it should not create any shadow. So while we are doing this process, how much comfortable the patient is, how much comfortable the patient can go closer to a target, or the near objects can be brought closer, what kind of colors they are comfortable with. So we should keep all the things in mind as per the diseases of the patient, which can be life-changing for them. So the overall question why we are prescribing to give them independence, to increase adaptation to the daily activities material, and to give them exposure to enriching experience, because they need to enjoy their life too in the best possible manner. And as per the American Academy of Ophthalmology and Optometry, few guidelines have been prescribed when to prescribe the low vision devices. So, as per the optical aids for near vision, usually they are introduced when the reduction, between the distance and object does not allow the necessary range or necessary change. So, till a point, when we are doing the examination, we are always noting down what level of font the patient is able to read and at what distance. So in our, low vision evaluation files, we have that, range set till what level the patient can see. Suppose a 10 centimeter, 15 centimeter. So suppose the patient is reading an 8 font, and till what range, that range can vary from 25 to 20 centimeter or 15 or 8 centimeter. So it is important, how comfortable the patient is, or if if the accessory or the unwanted, accommodative effort is required, which may induce the strain or headache to the patient. For the school-going children, vision up to 20 by 200, the distance can be reduced till a point the accommodation is, the recommended until the second grade. After a certain point of time, the font in their textbooks is also become smaller, and their activities of the school activities are also going to increase, which might put unwanted stress. So from this stage, a stand magnifier or a hand magnifier can be tried or can be given for the small print books. For visual acuities less than 20 by 200, that is zero point 0.1 logma, optical aids should be prescribed earlier if the visual acuity is less than 20 by 400, or if there is a central scotoma greater than 30 degrees, video magnifier is indicated, because whatever the optical aid you will try, that optical aid, tends to enhance, to make the things bigger. So if there is already a central scotoma, that scotoma would be enlarged and the patient won't be benefited with any of the optical low vision devices. So here, we require the necessary of video magnifiers or cameras or digital devices. And we must not wait for vision to go down, because if we are seeing a patient with RP or ARMD or any of the degenerative disorders, or which tend towards low vision, we must be briefing the patient in advance in order to get adapted to different challenges the patient might fall over the course of time. For visual acuity less than or equal to 20 by 800, where the vision is significantly low, there is a profound vision loss, the braille and computer system should be included. That comes under the inclusive or the special education, and the mobility and ADLs should be taught to the patient. So how to prescribe? We usually, we estimate the best corrected visual acuity for near and distance. And we always try to estimate what the patient requires. So understanding the patient needs is crucial to provide any low vision aid. We calculate the magnification. So there is one Kostenbaum formula, which is oftenly used to calculate the magnification. So it is, what is the visual acuity of the patient needed, and divided by what is the target visual acuity achieved. So suppose the patient is reading 6 by 60 or 20 by 200, and the target visual acuity is 20. So we divide it to 200 by 20, means the actual visual acuity, the best corrected visual acuity with the glasses, divided by the target visual acuity. So 200 by 20, or suppose 6 by 18 is the vision and the patient requires to read 6. So denominator is 18 and we divide it by 6. So we get it, 3x. So 4 is the unit of magnification. So 1x is equals to 4. So we divide the value which we have got 10 divided by 4. So in this case, we get 2.5x. So it is very, very simple. And we select the aid according to the characteristics of the device, the needs, the goals, and the clinical aspect of the patient. We don't want to unnecessarily burden the patient with the devices, and to achieve better acceptance of LVA, we need to have realistic approach towards needs, goals, and ability to handle the aid as well. So suppose a patient comes with the trimmer, or elderly patient who is not able to handle the handheld magnifier, the neck magnifier can be given. So we must know the range of magnifiers we have, and we must choose as per the patient age, environment, need, goals, aesthetics, weight, cost, and timing of the prescription. So it is important for the child to be comfortable with the aid proposed. We must not burden the patient. Uh, for the near concerns specifically, we must tailor the treatment. There must be different devices for the different activities, and we must consider ADLs, educational, vocational, recreational tasks, the patient's skill in using the devices, and advantages and disadvantages of the various devices, which can be extra magnification, increased learning curve, and all these things. So tips, for the near optimum print size: what is the contrast of the educational materials, lighting, glare, optimum lighting and glare, magnification aids such as adaptive devices and technology, viewing strategies, contrast enhancement. So, in terms of illumination, positioning is very, very important. And many a times, the patient, we have advised the patient to use lamp, but they complain of shadow vision or something like this. Higher level of illumination is needed in patients with lost cone functions, glaucoma, diabetic retinopathy, RP, and reduced illumination in albinism and aniridia. Pinhole glasses can be, are usually underestimated, but they can be very, very beneficial. They don't help in mobility, but suppose in watching television or watching the vicinity, they can be useful in corneal opacities and patients with irregular reflexes. Glare reduction devices are usually given to prevent the unwanted light, and they can be, visor heads, and usually given in cases of cataract, corneal opacities, albinism, RP. Sunglasses, umbrella, polaroid glasses, noise filters, CPF glasses are, very commonly used, and we use Polaroid and Neuer filters and photochromatic glasses very, very often. So, prognostic for, prescribing the devices, the ocular condition causing the visual impairment nature and extent of vision loss. Always the magnification and the type of device depends upon this. What is the goals of rehabilitation, patient's physical and mental abilities? Patient attitude is very, very important, you know. They must be motivated, and we should expect, they must expect the reality out of this. Because sometimes the message is conveyed, you know, from the OPD that you will be given a glasses which will help you see better. And we are trying the telescope. So you know, they keep on asking. We have been told that there would be any glass. So they want some magic out of it, but we need to, you know, set the expectations very much realistic. Otherwise, the device will go waste. Clinicians' attitude and motivation, you know. So I appeal to all the ophthalmologists who are primarily seeing the patient, must guide the patients in a very appropriate manner, and early referral is the key. So the number and frequency of follow-up visits on the stability of eye condition, patient response to therapy, specific visual devices. So this is one of the case where I think it is optic atrophy, where there is a central scotoma, but the peripheral visual field is good. But the BCVA is 1/60, and left eye is finger counting close to face. Right eye central scotoma, left eye vision was very poor, so field cannot be charted. So we tried 8x telescope, you know, 3/60. It was just for trial. Central scotoma telescope is not an ideal device which can be given to the patient. So basically, patient could not see blackboard and difficulty in writing in a straight line. So we had advised to use a portable video magnifier, which improved the vision to N6. Preferred retinal fixation in this case because patient needs to learn to see from the peripheral, you know, retina, preferred retinal fixation. Video magnifier, sketch pen, big fonts, lamp, letter write guide, or typoscope, or glasses with umber tint were useful, and the patient is enrolled in inclusive education. So this is one of the case, 90-year-old child, old patient diagnosed with retinitis pigmentosa. Patient had to left studies due to low vision. Right eye vision was finger counting 3 meter, left eye 4 meter. And the near vision is very poor, N36 at 20 centimeter. It means the patient had to bring the objects very, very close. So that was really a challenging condition for reading and writing. And with the spectacle, patient improved to finger counting 4 meter and 5 meter just, but telescope played a very important role here, and which the better eye, the left eye improved to 6/12, and the cycloplegic refraction was done. So whatever the devices we are trying with the after the cycloplegic refraction, depending upon the age, and with the proper prescription of glasses. For near, we tried the handheld magnifier. He improved to N10 parts. With video magnifier N6, but video magnifier is expensive and cannot be carried in exam halls, you know, in school. So mobile low vision applications were guided, and we advised the patient to use telescope with handheld magnifier, dark pen, guided for vocational training with integrated education, and use brighter illumination. So patient has been enrolled with NGO and under vocational training and doing well. So one of the case, 35-year-old patient where RP with optic nerve sequelae, very, very poor intervention for the right eye, but left eye was 6/6 parts. So ideally, we see the vision 6/6 parts, not a case of low vision, but visual field, tunnel vision, very, very constructed visual field, central 10 degree, you know, was present, and patient was struggling for the mobility. And being a household, she was having challenges with the kitchen and work related challenges. So CCTV and video magnifiers were helpful for reading. Smart vision glasses were tried and prescribed patient. Smart vision glasses are scanners and readers basically. And smartphone based low vision applications like Kibo and Vision. And we referred the patient to Dr. Suraj for visual rehabilitation and mobility and training. Environmental modification can play a big role. So, you know, a bit of guidance for better illumination in kitchen, like using contrast items for milk and pouring tea, or use of chopping board, and prefer retinal fixation for and head tracking for peripheral vision, and use of smartphone based applications can be very, very helpful. So we must remember to review, evaluate, and update our all low vision cases and make the images bigger, bolder, and brighter, and counsel the patient for patience, persistence, and practice. So patient should also have the patience, and practitioner needs to have the patience at most while evaluating a low vision case, because it is, you know, very much time taking. So this is the snapshot for the distance magnification and the near magnifications, what we are using to prescribe for mobility, environmental modifications, for photophobia, contrast enhancement, glare and photophobia. So thank you so very much. At RP Center, we have seen in a decade or more than 10,000 patients, and patients are really doing well, and we do feel very good. Thank you so much for the opportunity. Hello. Hello.
Thank you, Mrs.
Mansi.
Sneha. Thank you, Mrs. Sneha. That was an excellent presentation and so comprehensive about the prescription of low vision devices in different conditions. And I hope that all of us will use these tips if we are working in low vision settings. Any questions from the moderators or the audience?
In fact, the basic purpose of prescribing for a patient of low visual aid for any patient, in fact, I would say the word of wisdom are that how we can improve the low vision to a useful vision. So that is our job. What the disease patient having, that is different. It definitely is a terminally ill patient with the eye disease as far. So the vision cannot improve by any surgical or medical. That is one of the things where we have to think for low vision aid. So I mean, with from complete assessment of the patient age, its occupation and everything, the basic idea of as a ophthalmologist, as a optometrist, our thing that we should convert this existing low vision, whatever it is, to a useful vision for the patient. So that is the total nick of this. But it was a really good overview of everything. Thank you so much.
So,
So our next presentation is by Professor Suraj Senjam sir. He's a professor of community ophthalmology at RP Center, and sir is leading the assisted visual rehabilitation services at RP Center AIMS. Sir has plenty of experience in managing different types of low vision, and not just the optical but the non-optical and advances in assisted visual rehabilitation. So over to you, sir, for your talk.
Okay, thank you, Manasi. So let me share from my sites. So I hope it's visible now. Is it visible?
Yes, sir.
Yes, visible.
Yes, sir, it's visible. You can go to
Okay,
slideshow,
okay.
the full screen.
Yeah. So thank you, like those for this opportunity. So I'm very happy, and delighted to have, like talk on this vision rehabilitation technology. So as you know that now that when you say the low vision aids, so the low vision aids itself comes under the assistive technology for vision. So now that the terminology has changed so much, like in the ministry, in the WHO, in UNICEF, in UN. So we use the assistive technology because this low vision aid is a one component under the assistive technology. So in vision. So as you know that today, so I will be talking about a little bit comprehensive about assistive technology because this is a relatively new term for all of us. So if I ask, ophthalmologists and optometrists or any other person working in the eye sector, so they may not be, very much aware of this assistive technology because this is not very old. So recently in 2000, the WHO initiate this term in 2016 onwards. So, and then last 2 years ago, the WHO has conducted one survey that is called, Global Assistive Technology Assessment. So that ophthalmology is very much part of it. So with that, I will start with this. So before we talk about this rehabilitation and assistive technology and the low vision services, so first we must know the disability. So the concept of disability is very, very important because while we manage the person with disability, for example, visual disability, low vision, and total blind, so we cannot focus only the impairment parts. So there are other things also we need to look at. So at the same time, and whenever we see someone who's not, who has some visual problem, so we always think about, okay, the person is cannot do this work and he cannot read, he cannot go, he cannot recognize face. That's because of his vision impairment. But it is not like we never think of, okay, other components which can help, other devices which can help in terms of identifying, so reading and mobility. There's so many other things we hardly think about it. So we never, I mean, consider while managing the person with disability only that impairment part. So other factor in social components, environmental components like there are very very important while managing a person with disability. So with that, so we do have some case studies. Suppose this child is RUE, 6 years old female. So she said, "Sir, I'm not it." So and then now once he said, so what should be the appropriate assistive device? So there may be some assistive device that we call it optical device. There may be some like non-optical device, for example, large print book. There are so many other devices which really help the child to read. Next is this small child stays for ROP. So the child is not able to walk properly. So to start working independently, so we definitely need some kind of assistive device. This so-called we say walking cane, children walking cane. So so this is the case we try to teach the child how to use a walking cane because the child has never seen how people walk in his life. So so these are the clinic that's more on the vision rehabilitation and assistive technology training. This AT is assistive technology training. So we have a complete full-fledged, including it includes the optical devices, non-optical devices, and those ICMD devices, AI-based, AI-enabled devices, and of course AR-enabled devices as well. And this is a team we have particularly focused on rehabilitation and also those training part because assistive device and assistive technologies when providing the training part is very crucial. And in every morning, so I have to give some kind of training how to what are the different types of assistive device, including optical, non-optical, and at the same time, so our residents also so needs to be trained like how what are the different types of assistive device and assistive technology. So these are a wide range of assistive device, in terms of providing training. So this, for example, is how to use a dome magnifier because assistive device is not like like a medicine. So when you prescribe the paracetamol, so you can ask the patient with a glass of water, you just swallow it. But assistive technology is not like that. So you have to once you prescribe, recommend. So we need to provide a proper training. Otherwise, a patient will not be able to use what we expect, what we what are that assistive products supposed to be used. These are various range of training. This is the Victor Reader we call it. This is the assistive device for the blind, and this is the DESI book, and this is smartphone training. These are a very wide range of training that we provide in our clinic. So these are the flow that we follow in our rehab center. So first we register and we do some kind of need assessment, and the certificate is very very important because the blind and low vision persons they need some kind of help in terms of applying the certificates because nowadays all because of digitalization. So the person with the visual impairment and low vision they face a lot of challenges in terms of certificate application. So this is very important. So far we have helped around say 500 patients in the last 1.5 years in terms of applying certificates. So now coming to the assistive technology. So one must know what is assistive technology because as I said, this is a quite a relatively new terms. So the assistive technology in vision, assistive technology in hearing, assistive technology in locomotor, assistive technology in cognition, there are wide range, but in vision, so we do have a lot of assistive devices. So this assistive product before you go to assistive technology, so we must know what is assistive product. So the assistive product is a simple product. So maybe hardware, maybe software, so which can help a person to improve the functional limitation. At the same time, when you said assistive technology, so once you decide a product, and then technology comes, how a person who need the assistive product to be able to use the product efficiently and productively. Okay, so that means assistive technology includes the product plus a quite range of component, maybe in terms of assessment and prescription recommendation, and also training. As I said, training is very, very important, training and retraining and maintenance and repairing. So assistive technology, it includes the product as well as the service attached to the assistive product. For example, spectacles we have. So a spectacle is a product. So to use this spectacle product by a patient, by end user, so we need to assess, do some kind of detailed assessment, clinical evaluation, and you prescribe it. At the same time, you have to provide some kind of training. So the assistive technology term itself is some kind of umbrella term. So remember, the assistive products are not a device to treat and cure the problems. So the classification of assistive technology, because as I said, so the low vision aid is one component of the assistive technology, one part. So when you classify the assistive technology, so we do have visual based, those optical devices, tactile based, and sound based. These are the assistive based classification of assistive products so far, and the literature, and also in terms of education purposes. And so, for example, doing a daily living activities and other day-to-day works. The first we classify the assistive product for the pre-academic learning and reading, mathematics, science, orientation and mobility, and games and leisure, and also living activities. So alongside their examples given here. So there are how many people with visual difficulties needs assistive product in a country. So recently we have published one research in a Lancet. So you'll see in this table, so seeing difficulties. So in seeing difficulties, in the study, something, some technical issues. Is it visible now?
Yes, so
Yeah,
you're
it is
connected
there.
now, but we can't see your screen.
Yes.
So you need to share the screen again.
So you can't see the screen
We
No,
can't see the screen.
now.
not yet.
Okay, let me just.
Share again, I
Okay.
hope.
Yeah, let me share again. Yeah, okay. Yeah, I'll share it again. Now?
No, not yet.
It's not visible. No. Oh, Zoom. Is it visible now?
Not
Not yet.
coming. No.
What happened? Hold on. Stop sharing. Let me share again after the stop sharing. Let me share again. Should I log out or log in again?
We can try that. Now it's
Yeah.
showing. Yes. Start sharing screen. I hope it will come now.
Let me stop sharing for a moment and let me again.
Tariq, in the meantime, please help Dr. Suraj.
Sharing.
Yes, sir. His internet is
And now I think Dr. Swapn Samanta sir has joined,
Oh,
and sir
nice.
must be having a very busy schedule. So let's have his thoughts on this
Is it
topic.
visible now?
No, not
Meanwhile,
at
you
all.
help Suraj sir.
Visible now?
Samanta sir, welcome sir. Thank you for joining. Swapan Samanta sir.
Is it visible? No.
No.
Hello.
Professor Samanta,
Hello.
Yes, sir.
good evening. Good evening. We can see you.
Good evening. Good evening. Excellent going. Excellent going.
Your blessing, sir.
Actually, this is the most neglected chapter in ophthalmology, but very vital chapter for the community of ophthalmologists like us. Do you hear to me?
Yeah, we
Visible.
can hear.
I'm traveling.
Yes, looking.
We know, sir. You must
That's
be
why.
traveling.
That's why
So it's still
Association
not
of
visible.
Community Ophthalmologists of India, ACOIN, has taken this particular chapter of low vision aid as our prime chapter for academic discussion during this current academic year from October 2024 to September 30th, 2025. And everywhere we are all discussing and preparing all our scientific gathering, focusing on this particular chapter of low vision aid. I am very much grateful to Dr. Prafulla Rana Maharana, our Secretary of ACOIN Delhi State Chapter, to organize such a beautiful webinar on low vision aid, and all our good ACOINians, Dr. Suraj, Sanjeev, and everywhere are there. Nice going,
Is it
nice
visible now?
discussion.
Yeah, visible.
Yeah.
Okay.
Thank
Yeah,
you,
so
sir.
this
We'll
slide,
come back to you. Let's continue with the
Okay.
lecture.
yeah, so
Okay.
now,
Thank you.
yeah, finally. So this is a study we did it, I mean, in terms of assessing the assistive technology need and unmet needs in India. So we found out, this slide shows how important, assistive technology as a whole when you talk about vision. Because the table itself shows, see the difficulties, so difficulties levels, some difficulty, severe and total difficult. So compared to the other difficulties, mobility, seeing, hearing, communication, and cognitive and self-care. So coming to the seeing, so when you see the some difficulty, it's around 23.3%, and severe and total difficulty is 3.3%. So this difficulty was assessed using the Washington Short Survey questionnaire. So that is a valid questionnaire. So that means that our fraternities, we should not ignore when you talk about assistive device and assistive technology for revision. And then how does AT helps? How does assistive technology for vision helps people? So the first is impairment. So we know that the AT reduce the impairments, they minimize the impairment, as Sneha highlighted. So someone is having poor visions and an assistive device, the low vision assistive device will definitely enhance the vision. And at the same time, the activity limitation. So using this AT, assistive technology for vision, and the daily living activities. There will be improvement in terms of performing their daily living activities, or so to say, minimize the limitation. At the same time, coming to the participation restriction, so using this assistive device, assistive technology, for example, smartphone, so the participation in the society will be improved. Say, suppose, for example, festival, for example, going to the outside, so and interacting with friends, so inclusions. There are so many other things which will helpful by using assistive technology for vision. At the same time, it will help in terms of education, employment, and self care. So there are so many other assistive devices, assistive technology in vision, impairment. So this is we use in the clinic. So how to recommend assistive technology in vision rehabilitation. So you see the last column you'll find, so that the first one is a definition, the wide range of vision loss. Second one, low vision and blind. So when you say low vision is less than 618 up to the 360, and blind is, we say, less than 360. And so for the assistive technology for vision, so when we recommend the assistive technology for visions, so broadly we categorize into two, like low vision up to 160 and less than 160. So this categorize is basically very helpful in terms of recommending the assistive technology for visual impairments. So let's see this one. So then category one, so the patient comes to our clinic, so we categorize category one, those patients with BCVA better than 160, and category two, those patients with BCVA less than 160. So here, a patient comes to you with a BCVA less than 160. Suppose we say finger counting close to face. So we usually encourage to use, especially for a reading purpose, to be able to use efficiently and productively. We recommend those devices based on a tactile and sound. And because those, for reading purpose, because reading means students needs to read a long term, so not for the sport reading. So we encourage to use those, patients coming with this vision category. But at the same time, we never, uh, I mean, say that do not use those magnifier. The patient is still able to use magnifier for the spot reading, for the short-term reading, so we recommend. But primarily, a patient comes to you with a vision of BCVA less than 160. That means finger counting close to face, like a zero point 0.5 by 160, like 0.3 by 160. So we encourage to use those tactile and sound-based devices for reading purpose and for other reading purpose. So here you'll see the category 1 and category 2 for education purpose, category 1. So we recommend those magnifier. Okay, those detailed assessment will be done by those optometrist low vision specialists. This is the broad classifications, and category 2, that is the BCB less than 160. So, and we encourage to use tactile and sound-based assistive device, assistive training, assistive device. At the same time, for orientation and mobility, for category 1, we recommend a guide cane, because they still have some vision, some quite a a vision function. And whereas in the category 2, so we recommend a guide cane, rather than using the walking cane. So this is as an example. A patient comes to us, Parasum male, 55 years old, from Bihar, and then his vision was, see, in the right eye 260, in the left eye 160, and the near BCP is the N36 by N5 centimeters. And our low vision team downstairs, they have recommended this illuminated handheld magnifier 5x to 50, and with this improved N18 at 10 centimeter. So for this patient, since the patient has this much vision, so we recommend for a smartphone training as a WeZoom. WeZoom is such a apps, special apps to be used by a person with a low vision. Okay, so this is a training we provide this person, the smartphone apps, because this person still has some kind of visible vision. So we provide training how to use a WeZoom. See, can you see this?
आपको पता चल रहा है कितने का अमाउंट है? कितने का है? 10 रुपए का है। 10 रुपए का है। कितने का सकता है? 10 रुपए का वेरी गुड। अगर आपको नहीं दिखाई दे रहा ना, तो आप इसको 50 रुपए और भी बड़ा कर सकते हो। 50 रुपए और इसमें भी आप कलर चेंज कर सकते हो, जो ठीक लगे उसमें देख सकते हो।
मेरे को ये बताइए कि पहले क्या क्या चीजें आप नहीं कर पा रहे थे, जो कि इस बीजीन ऐप जो उन्होंने समझाया है उसके माध्यम से आपको बहुत अच्छा लगा? हेल्प मिला मेरे को, अच्छा लगा, बिल्कुल अच्छी तरह पढ़ सकते हैं आप। हाँ, क्या फोन की बैटरी खत्म हो रही है कि पहले देख पाते थे? नहीं सर, अब
So this is the smartphone use, because this person is his vision BCV is better than 160. So we provide those special apps to be used by a person with low vision. And what will happen at the same time? These are some of the apps, for a distance vision. What will happen to this fellow? He's a PL positive. So we cannot provide, those WeZoom training for this because he is not able to see it. Then what sort of, special apps to be recommended? Because his vision is, less than 160. It's very, very poor vision. So the WeZoom is not benefited for him. So in this case, so we provide those screen readers, training how to use the screen readers. And like TalkBack, we have a voiceover, and these are some of the special apps to be used by a person or a less than 160 vision cat BCVA. So you will see here, this person is without looking at the mobile phone. So he is able to operate very easily. So those low vision apps, so it's not used for him. So being a trainer, so you should be able to decide, a person comes to you, which apps will be good for a particular patient and be having this much of vision.
Professor Suraj, may you bind up, please?
Yeah. This is the last slide, I think. Yeah. So there's some initiative from WHO. So this is a priority assistive product list. So there are 16 assistive product lists under WHO APL. So 16 belongs to the visual disability. And this is the another Ministry of Health. There are 21 lists. Out of these 21 lists, 7 are belong to vision related devices. And these are some of the wide range of assistive products. We have magnifier, we have large screen keyboard, we have emboss educational material, cane, we have braille, color detector, language sensor, this is the navigation map. This is a wide range of assistive product. And these are the high-end assistive product. Advanced, these are some of the products are AI based, some of the products are augmented reality. So if anybody wants to know the detail about this product, ICMD device, we call it. So it is those time we published a year ago. And very quickly, but last not the least, but this community-based rehabilitation is one of the very, very important area while providing low vision rehabilitation in the hospital. So this matrix used very frequently. So this matrix is very, very important. We need to explain the patient's needs in terms of this component, needs in terms of health, education, livelihood, social, and empowerment. So we frequently use this matrix. It's very, very popular in terms of providing community-based rehabilitation. Thank you.
Thank you, sir. I think
Thank you.
it's already about 9. So let's have a quick comment from all our panelists. I think Baveja sir has joined us. Dr. Baveja. I think sir has already left. Swapan
Okay.
sir, you were saying something. Last few words, sir, then we'll conclude.
Yes, he's here.
I think, sir, OPR sir, you have to conclude. I think some audio issues are there.
Dr. Prafulla was one of the best meeting I have heard over the most awaited topic from such a long period. What we have to do, I think a lot of things has been discussed. There are a lot of repetition as well. What I feel that as of now, we are looking, if you are going for the document, we found that the visual disability is characterized in the percentage, right? So there are a lot of things has to be done to describe that 45% or 48% percentage of visual disability is required for getting a job in that kind of disability category. Second thing, what I think that I have requested that we have to frame some guideline not only for the job seekers, but for the society as well. Third thing, this thing is not being publicized well. I mean, if you are in the same category of the person, like we don't, even the ophthalmologists don't know where these services are available freely and what kind of service can be provided. So we are having a thought block, the person who's having a terminal visual handicapness because of some reason. So I think the peripheral center should have this facility, and we should have use this the media just to give the advertisement that the people definitely can, this kind of patient can be definitely helped with the available means. So that is my request. But definitely you did a wonderful job. I pay my all thanks to you and to all the learned speakers. They did very well. They have a lot of material, and it is eye-opener for me as well. Thank you so much. And I take blessing from Professor Samantha. He's here despite his all very, very busy schedule. I think we are very happy to see him. Very good evening, sir. And definitely it will be a good blessing from your side. Sir, Dr. Samantha.
Good evening. Yes, good evening, Dr. Prafulla. It's an excellent discussion over webinar. But what I just like to emphasize that during February, I had the opportunity to travel in Odisha with Distirath Jatra in 2 districts, one at Raurkela and other in Mayurbhanj. And I had the privilege to visit 2 big blind school, government blind school, one in Raurkela and one in Mayurbhanj in Baripada. And more than 100 blind children are there. And many of them has got residual vision, but they have never access of any sort of all the assisted technology, low vision aid. So what my earnest request, don't like to keep all the webinar or anything only in discussion, only in theoretical, but we have to make it in practice, how we can reach all those poor guys in those blind schools with all those beautiful assisted device. But everywhere, suppose in Baripada, week before last, I have seen 90% of them are from poor tribal. They have never seen all those assisted technology, but many of them has got this very residual vision. So we must have to frame some sort of guideline so that we can reach all those places with at least very minimum facilities of low visual aids. With this, I like to make my conclusion that we have to be practical in our community eye health services everywhere in the country. Thank you, Dr. Prafulla, once again.
Very right, sir. Very right words. Thank you so much. Dr. Prafulla, please.
Yes, Swapna sir, this is what even we decided. He will not keep it only at webinar level. We'll come out with some printed material so that we
Yes.
can at least inform this blind school that these are the options available. And
Yeah.
if you want, these are the contact points you can access through that. And even we'll coordinate with few NGOs. If they agree with us, then they can be the mediator between the blind
Yes.
school and the low vision clinic at RP Center.
And
I think Shrop Charity also has some low vision clinic.
yes, they are also
So
having.
yeah, so we'll try to do that, sir. And
Thank you
any
very much.
panelist, any other comment, or else let's break for the dinner. I think it's already 9.
Yeah, I think. Thank you, really, Prafulla. You deserve a
Okay.
lot of thanks, and you
Thank
take a really nice initiative.
Thank you all the speakers, Mansi
Yes, Mansi,
and
Professor.
Mansi, Suraj sir, and Sita. But big thank you to Sarita ma'am. The idea came from her only.
Thank
Thank you,
you so
ma'am.
much. Thank you so much, Dr. Prafulla. It was
Thank you.
really a wonderful, wonderful webinar. And good evening, Dr. Samantha sir. Samantha Dada, good evening. How are you, sir?
Thank you. Thank you. Thank you.
Professor
Thank you.
Samantha
On
is
his way
always
to
young.
Nest Medical
I'm-
College.
Thank you.
Okay, Dada.
Right,
Thank
sir.
Thank you, Dada.
Thank you.
Okay.
Thank you.
Good night, everyone.
Okay.
Good night.
Good night.
Good night.
Thank you.
Thank you.
Good night.
Mm. Mm.